Thank you, Edward and Jasmine. And now to further explore barriers to access for diabetes technology, I'm going to turn to my colleague, Julia Manchester. Julia?
Thanks.
Take it away.
Thanks, Bob. I'm pleased to be joined now by a panel of distinguished experts. Dr. Ananta Addala is a pediatric endocrinologist and instructor at Stanford University. And Dr. Sanjoy Dutta is vice president of research at JDRF, a global organization funding type 1 diabetes research. And Dr. Gary Puckrein is president and CEO of the National Minority Quality Forum. Thank you all for joining me today.
It's our pleasure. Thanks for having us.
Thank you. So, Dr. Addala, I would love to start with you. Help our audience understand why these technologies that help people with diabetes navigate the disease, why they're so incredibly important to the quality of life.
That is actually the fundamental question, right? Before we can really talk about whether we should work towards coverage, is establishing that these are efficacious treatment. And I think that the data are overwhelming to the point, I think this has been said a little bit earlier as well, that international guidelines are very consistent that not only should diabetes technology be readily available to youth and individuals with type 1 diabetes, but also that we should consider expanding that. And it seems like the reason why diabetes technology is so helpful is because when you know your blood sugar numbers with as little effort, there's still effort. I cannot underscore that enough. There is an overall improvement in your ability to act on those numbers and your ability to prepare. And particularly type 1 diabetes is a sort of constant management, and this really offloads some of that burden. And then the other piece is that there are many data that are available that talk about the quality of life improvement, the fact that parents are getting more sleep than they used to, and so are adults who are living with type 1 diabetes. And this benefit extends outside of type 1 diabetes alone. And that's sort of one of the things that I think it would be important for us to start looking ahead, not only modifying our current coverage policies to simplify existing coverage, but also expanding it to other insulin-requiring diabetes is likely where we should be taking it, because it is effective. It's been proven time and time and time again in small-scale studies, large-scale studies, diverse individuals. The evidence is overwhelming, and I think it's time we start acting.
Right. And on that note about expanding coverage, Dr. Dutta, I want to go to you. We know that technology has advanced over the years in treating people with diabetes, but unfortunately, as we've seen this technology improve and expand, there's been this disparity in who has access to that technology. Talk about how, there is this gap in access to these treatments.
Thank you. Thank you for inviting me. An excellent question from you, Julia. There is certainly an issue with access and affordability, especially in the lower socioeconomic strata and certain ethnic groups, subgroups there. And that is important to address. That is at the root cause of this. However, we will be missing the forest for the trees if we are only relying on access and affordability, which definitely need to be improved. And JDRF is doing significant work with the private and commercial payers, Medicare and others, to address that. There are additional issues that in our system, which is essentially broken and needs to be fixed here. And we can't attribute it entirely to access and affordability. For example, there's a significant lack of specialists providing diabetes care: endocrinologists, diabetologists, nurse practitioners, psychology specialists in diabetes. There's a significant lack there, especially in certain rural and ethnic communities and lower socioeconomic strata. There are, we know, cultural barriers. Some of them are historic and some of them are recent. Then there is a trust issue that is lacking, and that is something that can be built through a systemic change in the process here. There are significant medical care disparities in the US as well as outside the US. When you control for zip code, even the socioeconomic strata and all other variables, you still see a medical care disparity, medical care delivery disparity given to a white individual versus a Black American or a Hispanic American. And those are systemic changes that we need to do. And then finally, there's also a lack of people that look alike and talk alike that are delivering the care. And we need to do something to train the individuals so that the future generation have a diversity even in medical care delivery experts, and not just in looking at the patient population that needs to be taken care of.
Right. And Dr. Puckrein, how do we make sure that people, regardless of their race or zip code or socioeconomic status, how do we make sure they're getting this technology into their hands or into their doctor's hands?
I think we have to begin with asking ourselves the question, what is the purpose of our healthcare system? And the purpose of our healthcare system is actually to reduce risk. Reduce risk for all patients who come into the system, no matter their color, race, gender, age. And what we're doing right now is we've decided that we need to ration care, and we use things like ability to pay or race as a way to decide who gets access to what medications and devices. And at the end of the day, what that means is they end up with poor outcomes. Their life expectancy is shorter, the quality of life is impacted. And so we have to really start to reimagine. I think that's what you're hearing. We have to reimagine our healthcare system and focus it around managing patient risk. Too much of our system is focused on financial risk. And actually what we're doing is we're sacrificing the lives of many Americans.
And I'd like to toss to an audience question from Simye at home. They have a very interesting question on this topic.
Hi, my name is Simai Okyai, and I'm a health policy manager at Applied Policy. Applied Policy is a consulting firm located in Alexandria, Virginia. My question for you today is, why do we think there's such a gap in people of color accessing diabetes technology such as CGMs? What can we do to really understand disparities when it comes to life-saving technologies like insulin pumps? Thank you for your time today.
Dr. Addala, if you'd like to take a stab at that one first.
I would love to, because I think that is such an important question to understand and start wrapping our heads around. So I think the question was, why do these disparities exist and what can we do about it, right? And so the why these disparities exist is, I think that it's multifactorial, essentially, is what it comes down to. The system is not primed to support individuals who are racial ethnic minorities or are from low socioeconomic status. And oftentimes those two entities, being a minoritized individual and having low socioeconomic status, they co-occur, but they have their dual and kind of independent driver of adverse health. And what I mean by that is that simply because you are higher socioeconomic status, but if you're a minoritized individuals, you have poor outcomes. There are plenty of data to support that, and vice versa. And so what I think is happening, and I think there's a body of literature to support this, is that there are multifactorial level drivers that result in inequitable care. So it's not on the community that's being marginalized or has been historically excluded. It's specifically on the system that set this up. And so that means it comes from the policy level. How are diabetes technology covered? Not only from the legislative standpoint, which is sort of the letter of the law, but the regulatory standpoint, how it's implemented. For example, in California, by county to county to county, there's variability in how CGM is covered for youth with type 1 diabetes. But the legislative piece is exactly the same. So there's that component. There's a level at the industry because you have to have the diabetes technology be approachable, right? It has to be in a number of languages. It has to be accessible in a way that makes sense to a diverse community. There's also inadvertently, I think providers end up playing a role in diabetes technology disparities, and there's some evidence to support that as well. I think it comes from being in the system that isn't really primed to support individuals who have been minoritized, who have been excluded, who come from low socioeconomic status, who have public insurance, specifically the population that we're trying to reach. And so I gave you a few very diverse and broad reasons why there's inequities. And that can feel a little overwhelming at times because it can seem like, well, the whole system's kind of worked against you. But what that also means is that there is multiple places where there's opportunities for each of these sectors to act, to modify, to pivot, and then move the needle towards disparity. And it really means it can be something that we all do in our day-to-day without sort of taking up the flag and saying, this is exclusively what I do. And so I think that is a wonderful question and what we should all be thinking about, what the next steps are, how we can change.
And Dr. Dutta, I don't work in the healthcare field, but I think for many of us following the news about the coronavirus pandemic and how it's impacted healthcare, it's really revealed and given us a closer look at the disparities that exist within the healthcare field and when it comes to healthcare access. I'm wondering if this had any impact on, access to people with diabetes have to that technology, to that treatment, and how the pandemic could have impacted the development of this technology. I'm not sure if I'm getting at something that's been covered widely, but I'm wondering if this has been a trend.
That's actually the very topical question for the last almost 20 months or 22 months. It's top of mind for all of us that work in the field of diabetes, type 1 diabetes, type 2 diabetes, and all forms of diabetes here. Some of these are the exacerbation is some of it is physiologic. For example, the coronavirus is what we call a pleiotropic virus. It affects many organs in the body. It particularly affects many of the metabolic organs in the body, like the kidney and the pancreas. And so as a result of which we have seen an increased incidence of diabetes, but we've also seen worse outcomes in people with diabetes. In fact, they are therefore categorized in a high-risk category for prioritization of the vaccines in the early part of the pandemic when the vaccines were not available. And there are other biological factors that have contributed to the disparity of it. For example, individuals with Black American individuals have some genetic predisposition to kidney disease, and those have been exacerbated during the pandemic. The non-physiologic factors that have certainly created a bigger, wider gap in disparity and access has simply been access to specialists, access to specialist care. You were not able to move out and about to go and see your doctor. Overnight, we had to transfer from an in-person patient-physician interaction to a virtual environment, and everybody didn't have access to it, particularly in the lower socioeconomic strata. Then there were also issues with job loss, rationing of insulin, rationing of food, and all of these things, and your lifestyle changes where your exercise, your movement, all of these things have totally compounded to lead to worse outcomes in people with diabetes. So what has happened is, unfortunately, that gap has only widened during the pandemic, and hopefully we'll be able to close it soon. And this has been an eye-opener for us as to what is inherently broken in the system, and we need to be working towards fixing it. As Dr. Addala said, there are opportunities here, and we should look at the opportunities and seize them as we recover from this pandemic.
And we're talking so much about the technology and the treatments, which is obviously so incredibly important to people with diabetes and the field of treating diabetes. But Dr. Puckrein, I would love to hear from you as to whether you think patients are getting the right education about diabetes, and if there's an awareness about the disease among people who could be at higher risk, or from people who don't know they're at high risk. Are they getting the right? Are they getting that information?
So in the National Minority Quality Forum, when we started looking at diabetes back in around 2000, somewhere around 3.5% of the American population had diabetes. Now it's over 9.5% of the population. We have an epidemic on our hands, and we're not addressing it. We're pretending like it'll go away. By 2030, we're talking about having about somewhere around 35 million people living with diabetes in the country. And we're not doing a great job in community. If you do a map and you look at where the diabetes educators, you're going to find that they're not in minority communities, that people are living with diabetes every day, but they're not getting the instruction and the way to manage of their disease. We're doing a god-awful job managing diabetes in this country. It's one of the largest expenditures in the Medicare budget. Somewhere around 40% of all of the cost in the Medicare program is with an underlying condition of diabetes. People living with diabetes in the Medicare program, 60% of them are going to the emergency room or have a hospital event every year. That's an insane number. And it's all because we're not doing what we're supposed to do. And even more importantly, what we have the capacity to do. We can do better. We're just not doing better. It's systemic inertia, and we have to really bring this to an end. Otherwise, what we see with COVID, you're going to start to see by 2035 with diabetes, the healthcare system is not going to be able to manage what is going on in diabetes in this country.
And on that note, I'd like to go to another audience question from Sarah Brown. She's the Director of Government Affairs at Prevent Blindness.
Good afternoon. My name is Sarah Brown, and I am Director of Government Affairs with Prevent Blindness. Vision loss and blindness from diabetes-related eye disease is one of the leading causes of adult blindness in the United States. What is industry doing to ensure that technology is visually accessible to people who live with diabetes and diabetes-related vision loss and blindness, so as not to create an additional disparity in access to diabetes care for the blind and visually impaired?
Dr. Dutta, I would love to get your insight on that.
Yeah, thank you very much for the question from the audience there. JDRF has a robust program in diabetic retinopathy here, and we've always had it. And I'm sure other organizations, such as yours, where the question came from, is addressing it. Blindness due to diabetes is completely preventable. Is completely preventable. There is very meager genetic association with the disease. So they are mostly modifiable factors. So it's almost criminal to not be addressing it. There are modern technologies available for imaging the eye early on. They are affordable, they're scalable now. However, we need to have a systemic push to make sure that they are available at a primary care's office. And then that can be recommended to a retinal specialist or an ophthalmologist here. There are sophisticated tools available for early intervention in these diseases before you progress towards vision-threatening blindness, when options are few and far between. There is ongoing research right now when you progress around the pathway of losing your vision as to get modern therapies such as regenerative medicine and other therapies to correct vision blindness, but that's not ready for prime time today. So there is a lot of opportunity here. The first thing we need to do is to educate the primary care practitioners to have screening tools. There are handheld devices that are, as I mentioned, affordable and scalable to be deployed at all of these clinics here, particularly in the adult clinics there. And then they can be referred back to a specialist clinic. So there are avenues there to protect using technology at this point in time.
It's really a topic we don't get to talk about enough, so I would like to thank all of our panelists again for joining me today. Dr. Ananta Addala, Pediatric Endocrinologist and Instructor at Stanford Medicine, Dr. Sanjoy Dutta, Vice President of Research at JDRF, and Dr. Gary Puckrein, President and CEO of the National Minority Quality Forum. Thank you so much to all of you.
Thank you.
Thank you.